So again, the risk of being, or the probability of being in the low risk category is only 10%. And so unlike Lake Wobegon, you're not all above average. So the second group are the patients that I would say have relatively average risk. This is the majority of patients. And trying to rate it finer in that category really doesn't make sense because our therapies are relatively blunt instruments as well. This is generally half to 60% of patients. And again, these are patients that will benefit from therapies, but our goal is to maximize efficacy and minimize risks. And so we'll make an adjustment in the therapy to maybe to trade off one or the others of those depending on the motivation of the patient to take on risk. The third category, though, are patients who are at high risk of disability, where without treatment, the disease almost certainly is going to fundamentally change their lives and limit what they can do. And in that situation, we tend to err on the side of efficacy, and patients, it's up to the patient, but they often will decide to take more risk to minimize the chance that they would lose any further function. Now, having said this, it is not necessarily the case that having a more effective therapy is always entails more risk. It's actually not true. It depends on the biological group that you're in. So there are situations where the most effective therapy is actually also one of the safest therapies available. And I'll go over that in a few minutes. Now, the relevant comorbid or other health problems that we need to know about is whether you ever had a history of cancer. That would impact our decisions about Gilenya, teriflunomide, and alemtuzumab. We also need to know if you've had a history of liver disease, particularly hepatitis C or B, because that can affect our decisions about interferons, rituximab, and Gilenya. Heart disease, very important factor for Gilenya right now. We believe that at least 6 of the deaths that have been reported worldwide were due to an interaction with Gilenya with pre-existing heart disease. Diabetes, again, Gilenya and interferons would not be desirable therapies for that particular situation. If you have other autoimmune diseases, there are sometimes opportunities to use the therapy to treat both of them at the same time. For example, if you have inflammatory bowel disease, Tisabri actually is indicated for inflammatory bowel disease as well as for MS. Also, there are other situations with rheumatoid arthritis or psoriasis or other diseases that sometimes we can combine the therapies to treat both diseases at the same time. So when I'm selecting a disease-modifying agent for a patient, there are a number of different ways of looking at the treatment effects of these therapies. So when we do a study, we have what are called outcome measures. And outcome measures are the different ways that we measure the impact of the therapy on patients. What most physicians and most patients are aware of is the relative reduction in the number of relapses people are having per year. That's called the annualized relapse rate. It turns out, though, that reduction of the annualized relapse rate, or even the reduction of the number of enhancing lesions on MRI, has relatively low predictive value for subsequent disability. The outcomes. So the other measures that are really important for determining long-term outcome are actually the probability that patients in the study actually worsen on a disability score called the EDSS by 1 point or more that was sustained for over 3 months. In other words, they got worse and they didn't get better. That's a measure that actually has the strongest predictive value of the long-term outcome of the therapy. A second one that has equally important impact on long-term prediction of disability is brain atrophy. So if a therapy actually reduces brain atrophy significantly, that indicates that they're less likely to get fixed disability over a matter of 2 to 4 years. No, just haven't got a new one. We need a new one. When comparing these therapies now in our clinic, we tend to focus more on these other outcome measures that often tend to be what we call secondary or even tertiary outcome measures in the study. In other words, they weren't the primary measure that was used to decide whether the study was successful or not, but they provide important information that allows us to prognosticate for an individual patient. The second things that we have to consider are the risks. And the way that we think about that is the risk of having a serious health problem as a result of using the therapy. That's called a serious adverse event. And those numbers do come out of particularly large studies, and they are relatively predictive of your risk of having that in the future. So in a way, it's sort of the risk of having a serious health problem. And we want to put that risk in the context of other serious risks that you face just because you're alive in the United States today. For example, your chance of dying of heart disease in the United States is 1 in 4. Your chance of dying of cancer is 1 in 20. Your chance of dying from a car accident is 1 in 164. And your chance of dying in a commercial airline crash is 1 in 20,000. What we would like to have is that the risk of a serious adverse event for you is at least in that range for the commercial airline crash and not in the range for these other ones. So we're trying to calculate the odds to get them as low as we possibly can. There also are tolerability issues. Those relate to how much do you pay on a day-to-day basis for the drug? How much does it stress your finances? How much does it cause pain, fatigue, other side effects? Those are tolerability issues, and those also are important in the decision-making process. And then there's the need for regular safety monitoring. For some of the drugs, we really don't have to see you very often because there's no laboratories we have to do on a regular basis. But there are other drugs, for example, alemtuzumab, where you have to have a blood test done every month religiously because of a rare but very serious risk of a disease called idiopathic thrombocytopenia purpura, a bleeding problem. So these are factors that you need to take into account when thinking about these therapies. And these are things that your physician really should help identify for you for the therapies that he thinks or she thinks are the most appropriate ones for your particular situation. And then you can make decisions inside that category. This is a point that is new to this field, and that is that some therapies actually do result in an improvement in function in most patients over time. The best example we have is natalizumab.
I think we got it, yeah.
Okay. So, best example is natalizumab or Tysabri. This is the IV therapy that's given once a month. And studies from all over the world have continued to confirm that the majority of patients on this drug are actually getting better year over year. That's something that we have not documented with many of the other therapies yet, but we hope to do so in studies coming up. However, there also are potential downside risks with some of the newer therapies of having a rebound effect of the MS if you go off the therapy. This is not true for all drugs. It is true for Tysabri or natalizumab. And this is a situation that also has to be taken into account when you're thinking about the therapy. So one practical implication of this is that if you're a young woman and you're thinking about therapy for MS, but you're also thinking about getting pregnant within 1 or 2 years, then putting you on Tysabri for a year and taking you off is probably not a good thing because this rebound effect would negate the potential benefits you had during that 1-year period. On the other hand, if you're planning on staying on the drug for 5 years, then compared to other therapy options, this still may be a reasonable risk for one to take. So these are the calculations that we're trying to do as we evaluate therapies for individual patients. This is a list of the therapies that are likely to be available over the next 18 months or are available now. We have 8 FDA-approved therapies. We have 1 off-label drug that we tend to use a fair bit, which is rituximab, and we're likely to have 3 more drugs approved within the next 18 months. On this particular table, I've just tried to list some of the different outcomes that were available. This table can be updated almost on a daily basis, and I need to update it at this point. The major point I would make on this, though, is that if you look at the annualized relapse rate reduction value, which is the most common way to compare these, the most effective therapies are going to be Tysabri, the anti-CD20s, which are rituximab, ocrelizumab, and alemtuzumab. The intermediate therapies are going to be Gilenya and BG12. And then the other therapies will be put in the moderate efficacy level. If you look at effect on brain atrophy and disability, again, you see basically the same pattern. The Tysabri and alemtuzumab and rituximab tend to have the highest levels of effect in those categories. The BG12 and Gilenya tend to have moderate. And then on some of the first-line therapies, the effects are relatively modest in these areas. And that's why, at least in our clinic, we tend to think more about using the newer, more effective therapies, if at all possible. Now, as I said, there are relevant biomarkers. Right now, we use the JCV antibodies assay to determine your risk of PML with Tysabri. In the future, there may be gene profiles or cytokine profiles or other ones that will also begin to measure, particularly as some of the newer therapies come out. This means that what we're moving into is in personalized medicine, where we not only look at your history and your MRI, we will look at the biological makeup of you to try to identify a more specific risk-benefit ratio for each individual drug to match your particular situation. This is an exciting time for us in medicine, where we can refine our recommendations more based on your own individual biology. Now, the